welcome you to tonight's session, Planning for the Future, Health Decisions Matter. I want to begin this presentation to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada's national office is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wadat peoples. It is now home to many diverse First Nations, Indigenous, Inuit, and Métis people. We also acknowledge that Toronto was covered by Treaty 13 with the Mississaugas of the Credit. I acknowledge the legacy of colonialism and the impact it has on all areas of life for Indigenous peoples, including healthcare. As part of Dying with Dignity Canada's adherence to the values of inclusion and people-centeredness, we're committed to working towards recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, First Nations, and Indigenous peoples related to end of life and medical assistance in dying. We will continue to work to listen to and amplify the voices of Indigenous communities in the discussions of end of life choices. Before I welcome today's presenter, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there is opportunity to submit questions. To do so, please type your questions into the question bar on the Zoom side panel. Please try to keep your question as concise and clear as possible. While we're going to try to get to as many viewer questions as possible, unfortunately, we may not get to everyone. If you have outstanding questions, follow the webinar or questions that are quite personal in nature. Please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. We'll be sending a post-webinar survey that will pop up on your screen after the webinar. It'll give you the opportunity to share your feedback. Lastly, this session will be recorded. Now to introduce today's speaker, Alexandra Kushliak holds a BA, a B.S.W, an R.S.W, and is an education consultant with Advanced Care Planning and Goals of Care Calgary Zone, Alberta Health Services. Alexandra received her BA Psychology from the University of Manitoba in 1979 and her social work degree in 1984. Over the past 36 years, she has worked as a social worker in the medical field, including acute care, rehab settings, and supportive living. She has brought her social work expertise in running educational groups for stroke units and the Cancer Society in Winnipeg. Since coming to Calgary 22 years ago, she has worked on several transition units, long-term care, hospice, and supportive living. Alexandra is a strong advocate for clients and brings her passion for clients' rights to advanced care planning. She has been part of the Calgary Advanced Care Planning Goals of Care team for 7 years. Alexandra enjoys teaching regularly offered courses, as well as going out to the public to spread the word that everyone over the age of 18 should have a personal directive. Thank you for joining us, Alexandra. Now, before I turn things over to Alexandra, we'd like to begin with a quick poll. See, the numbers are coming in. We'll give everyone a few more seconds to finish up. I think that's pretty good. I'll give another 3, 2, 1, and everyone's answered. So now we're going to share that poll results. Okay. Let's circle back to this later. For now, without further ado, I'll turn things over to Alexandra. Alexandra?
Great. Thank you, David. It's really special to be here. I did this presentation last year and so glad to be invited back. Just a reminder that April 16th is National Advanced Care Planning Day. So it's the best time to learn about advanced care planning and how, in terms of advanced care planning, is done in Alberta. So David has done a great job of introducing me. I'd just like to say that I do a lot of teaching with the public and I do teaching with the staff with Alberta Health Services. And especially with Zoom now, I'm able to teach all over the province. So that's been a really exciting addition in terms of to be able to teach staff way up north and also at the same time to be teaching staff in the south. So I'd really like to thank you today for joining us. I know we were talking in the beginning with David that it's easy, especially when you're at home, to after supper to land up on your couch. So I'm so glad that you chose to join us today for this topic. And I know, especially nowadays, we're all a little bit stressed. So in terms of the topic today, I'd like to remind you that at the end, I will be telling you resources. You have been giving a link to all the resources, and our Conversations Matter booklet pretty well has all the information that I'm going to give you today. So no worries about having to memorize things or to take notes unless you really want to. I do want to say, unfortunately, that COVID is still with us, and that this scene, is changing, but unfortunately, we seem to not be able to get rid of it. But I would like to remind you that COVID is like any other medical emergency, that we need to be prepared. We need to be informed. We need to know our options. We need to inform our loved ones what our options are. And we need to know what it means for us. So that really links into advanced care planning and the personal directive, because that's how we get ready for medical emergencies. We make sure that people know what our wants. And the best way to protect ourselves in terms of COVID, this is just a reminder if you haven't had it, is by vaccines. So I'm just giving a little plug for vaccines to make sure you have yours in your booster. So what am I going to go through today? I'm going to talk about advanced care planning, what it is, why we do it, how we do it. I'm going to go through a personal directives and give you ideas about what you can put in and why it's important to put things in your personal directive that's going to help your family make decisions. We're going to talk the goals of care and about the goals of care system. And through that, I'm going to show you a couple of videos because you don't want to just listen to me talk through the whole way. So I'm actually going to start with a video, and this video is actually from Australia. This is Dr. Charlie Cork. We'd like to show him because he does a really great job of explaining what advanced care planning is in a really quick and succinct way. So let's just start with Dr. Charlie Cork.
About 80% of people at the end of their life are in a position where they can't make their own decisions. I'm Associate Professor Charlie Cork, and I'm a specialist in intensive care medicine. Some people will say that my family know what to do, or my doctor will know what to do, and unfortunately they're wrong. When a family's got an advanced care plan and knows what their relative wants, it's enormously easier for the family because they haven't got all the responsibility of making these, what they see as impossible decisions. And it makes it ever so much easier for the doctors because doctors are trying to do the right thing. They just need to know what it is. I think advanced care planning, in a nutshell, is three important things. It's about thinking about it, and just thinking about it starts the process happening. Talking about it to your family, talking about it to your doctor. The third thing is picking a great decision maker, because 80% of us right at the end will not be able to make our decisions. Just at the end of life, the way the process goes, you're not able to make decisions, and decisions need to be made. And a great decision maker is able to talk to the family, talk to the doctors, make a decision, make the right decision for you, and to feel comfortable about it. And it makes the whole process so straightforward, so controlled, and so sensible. And that's really, really good.
So that was Charlie. So I'm going to break it down in terms of what is advanced care planning. So it's that thinking about and sharing your wishes for healthcare with people close to you. So have you talked to your family? Have you talked to your friends? And it's that all important part about choosing someone to make healthcare decisions for you if you cannot make your decisions on your own. And what we call that person in Alberta is your agent. And where we write this information down is in the personal directive. And that's where we make it legal. In fact, in Alberta, we have a Personal Directive Act that tells us what your agent's responsibilities are. It tells us what your healthcare provider's responsibilities are. So it's a really backup document that makes that personal directive so strong. You may wonder why I have the little man on the bottom of the screen. And that actually shows you that only 2 out of 12 people actually know what is advanced care planning. So I'm so glad you joined us today, because I want you to, after today, you're going to be our ambassadors to make sure that other people know about advanced care planning, because we have a bit of a problem in Canada. 93% of us think it's important to discuss what our advanced care plans might be with our family and friends, but only 36% of us actually do it. 80% of us think it's important to discuss it with our healthcare providers, but again, only 8% do it. Really low amount that actually discuss it with healthcare providers. And those are the people that actually need to know what your healthcare decisions are. 66% thinks it's more to discuss it with a lawyer, but only 7% actually do it, right? So we think it's important, we're wanting to discuss it, and we're even wanting to discuss it with our lawyer, but somehow we just don't have that follow through. Somehow we're not taking that next step. So I want to tell you, maybe because we're not taking that next step, why aren't we taking that next step? You know, my dad used to say, I've got my will, I'm good to go. What more do I need? I don't maybe need that personal directive. Well, if he died in the 50s, he probably would have been right, because the majority of us died suddenly. And there wasn't a lot of decisions to be made, right? So especially if you die suddenly. But now 85% of us will die in one of these trajectories. And if you look at the graphs, it's over time. So whether it's terminal illness, whether it's organ failure, whether it's frailty, it's all over time. I want you to, if you're familiar, I've worked in long-term care, and some of our residents are there for over 10 years. And the majority of residents in long-term care lack capacity, meaning that they can't make their own medical decisions. So if grandma, grandpa, if your mom or dad haven't talked to you beforehand about what they want in terms of the medical care, if they haven't appointed an agent, if they haven't done a personal directive, then how do you know what kind of care they wanted? How do you know who they wanted to make the decisions for them? So it makes it very confusing for families if we don't prep. So in Alberta Health Services, we actually teach that there's 5 steps to advanced care planning. So it's kind of a process. So the first one is thinking about your wishes and values, because for everyone, their wishes and values are different. What's important to me may not be so important to you. For some people, it's really important that they can climb that mountain. For me, not so much. For a lot of people, for me, maybe eating and talking is important because those are a big part of my lives. But for maybe somebody else, not so much. So we have to really think about what's important for us. Number 2 is learn about your own health. So we have a big, huge problem in terms of, if you're wanting to plan, you really need to know what next month is going to look like, what a year is going to look like, what 2 years is going to look like. If you have a medical condition, have you talked to your doctor about what the years ahead might look like for you? What kind of decisions may you need to make? Do your family knows what kind of decisions that may be coming up? So those are really important questions. Number 3 is choose someone to make decisions and speak on your behalf. We're really lucky in the province of Alberta. You don't need to choose your husband or your wife. You can choose a family friend. You can choose someone who doesn't live in your city. You can choose someone who doesn't live in the province or even the country. As long as we can reach them by phone, they can be your agent and speak on your behalf, especially nowadays with Zoom. A lot of people Zoom with each other on a weekly basis. You know, they know you well, even though they don't even live in the same country. And number 4, if you're going to ignore everything I say tonight, number 4 is really important. As I said before, have you talked to your family, to your friends about what your wishes and values are around your health care, so that if you got into a motor vehicle accident, would they know what you wanted? If you got COVID, they know what you wanted? And the fifth step is to document it in a personal directive, and that's where it makes it legal. So once it's signed, dated, and witnessed, your document needs to be followed by your agent and by healthcare providers and by your family. So it's a really great document to have to make sure that your wishes are followed. Remember my dad, he talked about that will. He thought that was all he needed. So I want to make it perfectly clear what a personal directive is and what it is not. So a will is a document that you give, you tell what you want to do with your stuff, you tell people what you want to do with your property, and it only kind of gets looked after you die, right? Nothing to do with healthcare. An enduring power of attorney is where you sign a document that you appoint someone to manage your money while you're alive. Again, nothing to do with healthcare or personal decisions. So the personal directive is the only document that appoints someone to make healthcare decisions for you if you're unable, and personal decisions. So in the province of Alberta, we actually need all three. Now, I can't make you have these documents, but they're kind of like insurance, right? So, you're not planning to burn your house down. You're not planning to get in a motor vehicle accident, but it certainly helps when you have insurance. And that's how I kind of think of these documents, right? If you don't have a personal directive, it's going to make your life a little messier in terms of for your family. Same thing if you die without a will, it's going to be messy for your family. And if you don't have anybody to manage your money, it might get very complicated. So remember, the personal directive is where you appoint someone called your agent to make healthcare and personal decisions. And it's very specific to the province of Alberta. And it's where you write down healthcare wishes and instructions. I always say the personal directive is the only document that actually tells us who you are. The rest is kind of property, the will, and the enduring power of attorney is property and money. But the personal directive should include what your values are, what your wishes are. And everybody's personal directive should be a little bit different, right? My personal directive is different than my husband's, it's going to be different than yours, because what's important to me is not going to be the same that's important to someone else. It's really important to know that the personal directive, kind of like insurance, only sits there until you need it, right? And everybody can have a personal directive, but we don't follow it until you lose capacity. And there's a very specific process and paperwork that needs to be completed with a physician or a psychologist and how you indicated in your personal directive. So the Personal Directive Act is very specific. So people can't start making decisions for you until that's completed. So there's no sort of fear about people taking over without you actually losing capacity. So you can write your personal directive on your own, with or without a lawyer. But what you should do is keep the original in a safe place. But I want you to give your copies to your agent. So for those people out there who said they knew a lot about advanced care planning, maybe you have a personal directive, have you given a copy to your agent? Have you given a copy to your healthcare providers, your family? And why do I want you to give out all those copies? Because if something happens, we want to make sure that everybody knows what you would want and everybody knows who your agent, because that's going to make it so much easier if something happens. And we want you to keep the original in a safe place, but we want to make sure that your agent knows where that safe place is. So there's no standard format for a personal directive. The Personal Directive Act has made it really easy for us. We can go to a lawyer, we can fill out the documents that we've given you today, links to it. You can write it on your own. As long as it's signed, dated, and witnessed, it's a legal document. It can be even from another province. As long as it tells us what you want and names someone as an agent, it can be used as a personal directive. If you've done a will recently or even 10 years ago, check your documents, because most lawyers will give you 3 documents all in one. So when you go in to do your will, you would have done probably the enduring power of attorney and the personal directive at the same time. The problem is, I know when you go to lawyers, you kind of tell them what you want and they tell you where to sign, and then you put everything in your safety deposit box or put it in a drawer somewhere safe, but you never really check it. So check your documents, because you might have a personal directive and not even know it. Because there would be 3 separate documents if you did your will. There would be your will, there would have been an enduring power of attorney, and a personal directive. And usually they would do all three for one price. And I don't want you to redo your personal directive if you've gone to a lawyer to do one, because when you go to a lawyer to do a personal directive, there's actually another layer on it. The lawyer will determine your capacity and write an affidavit to that saying, you know, this person is perfectly capable of doing their personal directive. So like I said, that if you just do one on your own, you don't have that extra lawyer, but it's still a valid legal document. So there's four main elements about the personal directive that I want to talk to you about today. The first one is the revocation of previous personal directive. Maybe you checked your documents and you look in your personal directive and it's not quite what you want to say, and maybe the agent isn't around anyone and you want to do it over. So if you don't include the first statement, I revoke all previous personal directives, then that one and your new one would have the same standing. So we want to make sure we revoke any previous ones so there's no misconceptions about which personal directive we should be following. Because legally, if you don't revoke, then we have to follow both of them. And when I was working as a social worker in the field, I actually had someone who had two personal directives. When he made a new one, they didn't revoke the previous ones. So they were both in play and they had two different agents. So it made it kind of fun for us as healthcare providers, not so much fun for the healthcare. So in terms of writing your agent, remember I said it's really important that you pick the right person to do that, but it's also important to pick more than one agent. And how you write the agent's names down really makes a difference. So a lot of people say, you know, I've got 5 adult children. I think, you know, they're capable of making decisions for me if something happens. And I want to name all of them on my personal directive. And they proceed to do that. So they name Mary and Bob, they go right down the line. That's fine. The issue is that they all have to make a decision together. According to the Personal Directive Act, they can appoint someone to be a spokesperson in the majority rules. But if it's anything like my family, that many people trying to make a decision would be kind of hell on wheels. So you have to figure out, is that a good decision for your family, for your situation? Another option is people say, I'm going to name Mary or Bob. They're siblings. And I think they can swap off into each other and make the decision. Again, how would happen in this situation? Mary could make decisions. If she goes out of town, then Bob could make decisions and they could swap back and forth. The problem with that is, again, they may have to make sure that they're on the same page, that they're going to make decisions the same way, or else, you know, it's going to be kind of complicated. But for some situations, maybe you have, you know, siblings, maybe you have 2 adult children that work really well together. For your situation, that could work. What we recommend, and what most lawyers would recommend, is that you choose a primary. So we have an example here, Mary, and then you can choose as many alternates as you would like. So we have here Bob. So what would happen is Mary would make decisions for you. Then if something happened to Mary, then it would go to Bob. Then if something happened to Bob, it would go down the line, right? So you sort of have a backup plan. In that situation, you know, it's great to have a backup plan. I had a lady who wrote out her own personal directive, was very diligent, chose her adult daughter to be her agent, which was a great choice, but didn't do an alternate. And what happened is, unfortunately, the adult daughter died before she did. So then she was left without an agent. So it's very important, however you want to do it, that you understand what it means when you name them differently, and also that you have a backup. I always think backup plans are a good idea. Now it gets to, remember I said that everybody's personal directive should look a little different, but what do I put in a personal directive? How do I make it look different? How do I make it so that the agent will understand what I want? So what you can put in your personal directive is quality of life statements. What's the most important thing in your life? What does quality of life mean to you? What does no quality of life mean to you? What does poor quality of life mean to you? And are there any situations where you would not want your life prolonged? So in my personal directive, I have written that if I can't recognize my family over a prolonged period of time, then I would not want my life prolonged. but that's what's important to me. So everybody's going to be a little different, right? We also can be more specific in our personal directive. If you have a specific diagnosis like cancer, like kidney disease, you may want to put in your personal directive. If I become incapacitated, please don't continue on with my treatments for my cancer. If I can no longer recognize my family, please don't continue with my kidney dialysis. But again, that's different for everybody. We can also put end-of-life wishes in our personal directive. And we have a lovely example on our website, Conversations Matter, where Deb Cook talks about how her mother wrote her personal directive. And in it, she wrote that at my end of life, I don't want to make sure that family is around me. I want to make sure there's music. I want to make sure I can look out a window. And at the end of her life, the family was able to do that for her. And I really think what a lovely gift, what a gift for the family, because they have the solace of being able to fulfill that for their mother. And knowing as an individual, I think that would be really great, knowing that my family knew my wishes and were able to do that for me. So in terms of witnessing, because remember I said that personal directive doesn't become legal until it's signed, dated, and witnessed. So who can witness it? Well, they can be 18 or older. They should initial where you've initialed. If you use the form from the Office of the Public Guardian, they need to watch you sign and date your personal directive, and they need to sign and date the personal directive in front of you. I would always remember as a social worker, I would be called in to witness someone's document, and I never failed. When I came in, they had already signed it, so I'd have to have them do it all over again. So they actually have to witness it, hence this term witness, you dying it, you signing it. I like to mention that Dying with Dignity does have on their website, under their advanced care planning kit, specific personal directive for Alberta. And you can go on there and fill out that one. You can fill out the one from the Office of the Public Guardian, or you can handwrite one, or you can go to a lawyer. There's lots of options how to do it. I think the Dying with Dignity is a great one. It's got lots of options, got lots of ideas about what to put in it. It also has very specific instructions on some things. If you're doing specific instructions, whether you're using this form or another form, I want to make sure that you think those instructions out. If you put in your personal directive saying, I never want tube feeds, well, sometimes people can have tube feeds for a short period of time for their body to heal, and then they're better, and then they don't need tube feeds anymore. So you have to be very careful in terms of that you're understanding exactly what you're putting in your personal directive, because under law, we do have to follow it. And if you put something that's not quite exactly what you wanted, it's going to be pretty hard to reverse. So make sure that it's really thought out, that what you're putting in your personal directive is something that you really want. But I do love this format because it gives you lots of ideas about what you can include in your personal directive. I do want to talk about medical assistance in dying and organ donation, because people always ask, can I put medical assistance in dying, a request for it in my personal directive? The way the laws are right now, if you're writing it out on your own, let's say you're filling out your own, not going to a lawyer, you can request it. The issue is right now we can't fulfill it because remember, the personal directive does not get looked at until after you lose capacity, right? And you have to have capacity to request medical assistance in dying. So you can't kind of ask for it ahead of time. Now, the laws have changed slightly, so that if you're assessed and approved for medical assistance in dying and have a date and sign documents that says that you want to continue with medical assistance in dying, even if you lose capacity, then they can go on and do that. But that's different from a personal directive, right? These are two different kinds of documents, and that's one for a specific situation. As I said, that's how the laws are now. I know people wanting them changed, but as it is now, that's what it's doing. So if you're doing your own personal directive, you can put in there, you request medical assistance in dying. We just can't follow it right now. Organ donation is kind of a different kettle of fish. too, in terms of your organs actually don't belong to you after you die. They actually belong to your family. And that's why we have in the registry's office, on your license, that if you're interested in organ donation, to make sure you let people know, that you let your family know, that you let your friends know, because after death, then if we've got the registration, we've got documentation that this is what you want, families are more willing to go through with that. A lot of families want to do organ donation, but if you haven't let them know that that's what you wanted, it becomes a very sort of difficult decision to make. So I want to make sure that if you want more information about medical assistance in dying, we're pretty lucky in Alberta. We have a website that's dedicated to it. It's got stats on there. It's got all kinds of information to it. Who would you request information from? And if you want more information on it, if you're not savvy in terms of going on there Googling it, but I'm assuming since you're on Zoom, you're probably good. You can dial 811 to HealthLink, and they will also give you some information. So I want to move on now to talking about goals of care. So what I've been talking about is that green bubble on the screen. So I've been talking about advanced care planning, having those conversations about your values and wishes with your family, making sure that you fill out that personal directive. And that's things everybody over the age of 18 can do, right? We can all do a personal directive. We can all talk. It has nothing to do with age. It has nothing to do with your specific health situation. It's about making sure you're ready for a medical emergency and have all your ducks in a row. But when we have healthcare issues, when we're in the hospital, we need another different kind of document in terms of if we have an emergency, the EMS people, your physician need to know what kind of care you need in the moment. So that if EMS came in right now, if I had collapsed, they would know what to do right now. And those conversations go with your physician. And that's why it's really important to kind of talk about your values and wishes with your physician and talk about that so that you can have that conversation with your physician so that they can determine a goals of care for you if you need one. So I'm going to show you a video about goals of care because that's the best way to sort of explain the goals of care. But on this next section, I want to remind you that you do not need to memorize this information. There's no going to be tests. You don't need to know this information. Why I'm giving you this information is that if you have this conversation with your physician, if you have this conversation about somebody else you're looking after, maybe an elderly parent or grandparent, then you're a little bit more educated about it and you'll have an idea about what they're talking about. But this next section is not for you to figure it out on your own. So our goals of care are actually put into three categories: resuscitative care, medical care, and comfort care. And it's just in terms of how aggressive that care is. And care is what we do to you. And that's why I always show a video, because it's pretty hard to figure out just by talking in terms of what that means. So that's why I'm going to show this video, but I do want to do a warning about this video. You will see scenes in the intensive care unit. You will see somebody being resuscitated. You will see some other scenes. Now, I want a reminder that it is a video, meaning that are actors. None of this is real. And also in terms of the person that's getting resuscitated is actually a very large doll. So it's pretty not real at all. But if you've been in an intensive care unit, if you've had a lot of healthcare issues, it might trigger you. So I do want to warn people. You can look away from the screen. This video is about 9 minutes long.
Goals of care are designations used by your healthcare providers to describe the general aims of your healthcare and the preferred location of that care. Decisions about goals of care usually arise over time through conversations between you, your family, or loved ones and your healthcare team. The process of thinking about, talking about, and documenting your wishes for healthcare is called advanced care planning. In a medical emergency, your goals of care designation guides your healthcare team to provide timely care that is both medically appropriate and reflects your personal values and wishes. There are 3 general approaches to care or goals of care: resuscitative care, medical care, and comfort care. In resuscitative care, the main goal of care is to prolong life by curing or controlling your health condition. This means that doctors and nurses could use intensive medical and surgical interventions, if these are needed, to keep you alive and could be expected to cure or control your illness. If your heart stops, they may perform cardiopulmonary resuscitation or CPR. You may have seen resuscitation or CPR performed on television or in the movies. The person usually recovers easily, but this doesn't tell the whole story. Resuscitation measures like CPR work best in emergency situations where the heart stops suddenly, but the person is otherwise pretty healthy. It's important to know that CPR normally cannot restart the heart or restore life when the heart has stopped as a result of a severe or terminal illness. In CPR, the doctor or nurse repeatedly pushes on the chest with great force and periodically puts air into the lungs. Electric shocks, called defibrillation, may also be used to restart the heart, and some medicines might also be given. If the patient's heart starts to beat again, most patients require a stay in intensive care and a period of rehabilitation before they are well enough to leave hospital, and some people are left with permanent damage from their heart stopping. Resuscitative care can also include using medications and other treatments that are provided in an intensive care unit or ICU. The ICU is a very specialized unit in a hospital with doctors and nurses who are trained in using special equipment and medications to care for very sick people. An intervention that may be used in the ICU to prolong your life is a ventilating machine. These machines are used if you're unable to breathe on your own. This means putting a tube which is attached to a machine down the throat into the windpipe to push air into your lungs. Because this tube can be quite uncomfortable, people are often given medications to keep them very sleepy or sedated. You cannot eat or talk while on this machine. If you have a potentially curable or treatable condition, ICU care might be needed to help you heal. The hope is that you will return to your previous health, but it is important to understand resuscitative care and procedures used with the aim of prolonging life may or may not achieve that aim of restoring your previous health. In medical care, the goal of care is also to prolong life and to cure or control your health condition, but without the use of resuscitative care and the ICU.
Good morning, Mr. and Mrs. Johnson. How are you this morning?
Medical care can be appropriate if your health condition is such that intensive or resuscitative care such as CPR and a breathing tube are unlikely to work. Or your wishes and values about healthcare may be that you would not be accepting of these intensive medical treatments. For example, if they are unlikely to restore you to a state of health that you would want. In the medical approach to care, your doctors and nurses will provide tests and treatments for any treatable problems that may arise. This approach may include surgery and medical treatments such as blood transfusions, kidney dialysis, feeding tubes, antibiotics, and other medicines or fluids given through your veins. Most of these treatments mean going to the hospital.
Of course. You know how much she loves dance. Okay.
Hi,
So, of
Pat.
course,
Good afternoon.
Some people want to receive only the life-prolonging treatments that can be provided in their home or in the care center where they live, even if this limits what treatments are possible. If your goals include a desire to avoid going to the hospital for treatment, talk to your doctor about what treatments may be available and helpful to you in your home or care center. When your health condition or your values and wishes reflect a goal of maximizing comfort and relieving symptoms, this approach is called comfort care. Your doctors and nurses will give you medicines and other medical treatments to help control uncomfortable symptoms such as pain, trouble breathing, or feeling sick to your stomach. The main goal is not to prolong life, it is to maximize your comfort. Resuscitative treatments are not used. Comfort care does not mean that you receive less care. It means the focus of your medical care is on quality of life and reduction of symptoms. People receiving comfort care are usually treated at home, in hospice, or in a long-term care center. However, sometimes hospitalization may be needed to provide optimum comfort.
You know, he feels a lot weaker when he can't keep anything down.
In the hospital, the approach to care will continue to be focused on providing comfort and relieving symptoms. It's helpful to keep in mind your wishes and to know about your own health condition when you are discussing goals of care. Resuscitative care, medical care, and comfort care can be divided into more specific subcategories called goals of care designations. These subcategories provide your healthcare team with important information to help guide medical decisions about your treatment. Talk to your healthcare team about which goals of care designation best reflects your wishes and health circumstances.
So I'd like to talk a little bit more about the goals of care in terms of this is the actual document that your physician would fill out for you. But I want to make sure that you understand that not everybody needs a goal of care, right? I don't have a goal of care because if something happens to me, the EMS are going to come in and they're going to do absolutely everything they can to resuscitate me, and the same thing's going to happen in the hospital. But if you want something specific or don't want something specific, that's when you need that discussion with your physician. So the goals of care is always filled out with your physician, and it's always after a discussion with him. If you're in long-term care or in a facility, it might be a nurse practitioner that's doing that conversation and filling out that document. So you really don't sign it, but you have a say in it and you actually have a discussion with it. So it's necessary to have a goals of care if your health changes, right? If you would not benefit maybe from resuscitative care, if your health is changing, or maybe your values and goals are changing. So the goals of care, like the video said, are in 3 sections: resuscitative care, medical care, and comfort care. But if you noticed on the document, they're actually broken up into smaller sections. So resuscitative care is broken up into R1, R2, and R3. And the best way to explain them is to sort of give an example of what they mean. So R1, I've been in a car accident. I am relatively healthy. I'm going to get whatever treatment that will make me better. I don't know what the outcome will be, but I want to prolong my life at all costs, right? So most of us walking around are R1, and children are R1 most of the time. So in terms of, we don't know what your goals of care is, that most people will be an R1. We don't need a document for that. R2 is different. I know that chest compressions will not work for me, but a breathing machine and intensive care will get me back to my active lifestyle. So R2 means is that this gentleman wouldn't get chest compressions, but they would still get a breathing machine, and they would still be in an intensive care unit to make sure that that gentleman got back to where he was. R3 is a little bit different. This lady says, I suffer from AFib, which is afibrillation, which means her heart doesn't always beat the right way, sometimes too fast, sometimes too slow. So sometimes I need to go into the intensive care unit to get my heart rhythm back on track. I do not want to receive chest compressions or be on a ventilator, as they will not return me back to the state that I value. So she would go into the intensive care unit, get the treatment that she needed, and then be again out And sometimes they actually make an appointment for the AFib when they go in to do that. So the next is medical care, and that's already that's when somebody's not going to get chest compressions, they're not going to be resuscitated, and they're not going to the intensive care unit. And the medical care is broken down into two, M1 and M2. I am willing to, M1 is I'm willing to go to the hospital for any appropriate medical and surgical treatments to try to fix the fixables. I would like to live as long as possible and maintain my quality of life. CPR, chest compressions, intensive care unit, and the ventilator will not help me, and if attempted, will not leave me in a state of living that I value. So my mother, who was 89 at the time, was still living independently in an apartment, but she had some medical conditions, and she knew that CPR and ICU and the ventilator wouldn't help her. So she was an M1 at that time. She was getting treatment for high blood pressure. She was getting treatment for some of her other health issues. They were treating her at home. But unfortunately, my mother had a stroke and she went to the hospital. She was M1 and they did their investigations. They were able to get rid of the clot. She didn't go into ICU. She didn't have chest compressions. And she eventually, unfortunately, ended up in long-term care. And now she's an M2. So M2 means I want to be treated where I live and not go to the hospital. I want what medical treatments that are available where I live to try to fix the fixables. When I go to the hospital, I just get worse and they cannot fix me. So my mother lives in long-term care. She goes out to get her macular degeneration shots for her eyes. Her blood pressure is still getting treatment for that. Any infections or whatever are still being treated. They gave her medication for that. But she wants to be able to stay where she is in long-term care, not having to go back and forth to the hospital. But if she fell and broke her hip, they would still take her to the hospital and get that fixed, but then bring her back right to long-term care because that's where her home is. So whether it's long-term care or at home, M2 means, you know, I want to be treated where I am. So the next section is comfort care or C care, and that's a little bit of a difference, right? Now we're not trying to cure people of their illness, but rather we're just trying to maintain and we're trying to make sure that their symptoms are under control. So again, with an example of C1, the focus of my care is to provide comfort and to treat my symptoms using whatever medical treatments that will maximize my quality of life rather than focusing on the length of my life. I may be at this level for months or years. So at this level, even though people are suffering from some disease process, whether it be cancer or something else, their treatments are not to cure their disease, but to make sure they're comfortable. So let's say there was a tumor that they had in their lung and it was causing them not to breathe very well. At C1, they still could have surgery if the surgery's point was to relieve the symptom, to make them breathe easier, not to prolong their life, because that probably wouldn't do it. So at C1, you can have surgeries, you can have blood transfusions, but the purpose of doing it is to make sure that you're comfortable at whatever level you are. C2 is a different level. That's when somebody is in their final hours or days of life, and all the treatments are focused on comfort and support of the family and the client and the patient. And this is C2 is a real indication that that person shouldn't be moved. So it's an indication to healthcare providers and letting the family know that you know, death is imminent. So I do want to make a point about talking about palliative care, because people think that palliative care can be only given at certain levels. Some people think M1 or C1, and palliative care is actually a philosophy. If you have a life-limiting or a life-threatening illness, you may be at R1, but receive palliative care, because palliative care is looking at all of you and making sure that all your symptoms are in control and doing the best we can. And people have been on a palliative care at R1, at C1, and anything in between. And actually, the new studies have found is that people that are, let's say, diagnosed with cancer are R1 because they're getting all the treatments that they can. They actually do better if they're referred to palliative care early on. So palliative care isn't really just about end of life. It's actually helping people to live longer and live better. So what are the next steps? I've done my personal directive. I've talked about advanced care planning. I've kind of got an idea what the goals of care are. So what do I do now if I think that's maybe what I want? So one thing is that we have lots of decision tools on our website. So if you go to Conversations Matter, and if you click it under it, there's all kinds of decision tools in terms of, should I be receiving CPR? Some of the things that I talked about. Should I be getting kidney dialysis? What happens if I stop treatment? And you'll notice too, there's all kinds of videos on the side too, the different ones. So there are certain things that you can think about before you have that conversation with your physicians. What would you like to know about your illness and what is likely to be ahead? Have you thought about that? And what is important for you to have a good quality of life? Is there anything that you're afraid of about your illness? And sometimes we don't ask, you know, in terms of the physician or the doctor doesn't ask us those questions. So sometimes it's good to have these so that you can ask your doctor some of the questions and tell them what is some of the things that you're afraid of, some of the things that are really important to you. And is there some kind of medical care that you do not want? Maybe like my mother, she saw my dad go through a lot of things. So she didn't want intensive care unit. She didn't want some of those things because she knew that that wouldn't be really what she wanted. So what you can ask your doctor is, what is my life going to look like a month from now, a year from now? What treatments will help me live the way I want to live? And what kind of treatments do to my quality of life? Is there any alternatives? And sometimes we don't ask the questions because sometimes the treatments, they can think of other things. I'll give you a good example. And I know my boss will let me share with you because I asked her. So my boss's mother had breast cancer and she was given a shunt, which meant that she couldn't fly, but she was never in terms of going and travel. So she didn't really know that when they put the shunt in. So that meant that she couldn't visit her relatives that were in England because she wasn't able to get on a plane to go there. And if they had known that ahead of time, they probably would have done something different. So it's really important that people know what your goals are so that they can adjust the treatments and change it because maybe it doesn't fit with your lifestyle or what you want to do. So I want to show you a couple of videos of, these are real people in these videos. The first one is about how a patient talked about advanced care planning with his wife and his doctor and talked about a little bit in terms of how that went. So it's a great example how advanced care planning is used in real life and how that discussion with this doctor kind of helped him and his family.
Well, I was diagnosed with pulmonary fibrosis in December of 2006, actually. And that was after about 5 months of various testing, the type there's no known cause for, and there's no cure. So it's a terminal disease. And it becomes very stressful when you're dealing with that sort of end-of-life disease. And knowing that there's no cure, it's progressed to the point now where I can do very little work, very little exertion, and I'm wearing oxygen 24 hours a day. Dr. Fell sat down with my wife Moira and I, and we talked about the different levels of care and got a good understanding of, you know, if things progress to the worst, what did I want to see happen? And how did I want the medical team to care for me, and what capacity. And the good thing was that my wife was there and we were able to discuss it, and she agreed upon it as well. So to come to a time when that decision had to be made, she knew exactly what the decisions were. Advanced care planning is a very difficult thing to do, and you know, over the past number of months, you know, my experience with advanced care planning has improved. My knowledge has improved considerably. My wife and I have a personal directive that was made several years ago. And I view the personal directive a little differently when it, you know, is done in that context. It's maybe a broader scope document, where this is a living document, and it engages not only, you know, your family members, your medical team, and yourself. And so it's a team effort as we kind of go through this process. And it's, you know, I think it's been a good experience for us, and one that I don't regret at all going through and doing and working through with my wife and family. As I say, it's one of those topics that you can easily procrastinate at and say, well, tomorrow is always a better day to talk about that. I think the advice that I would offer to someone that didn't want to get involved would be more to think beyond yourself and think about your family and to think about what value something like this provides.
So this next video is an example of that at any age, you know, something can happen, and that it really helps if we're prepared, even though, you know, that thing that happens, that medical emergency, may not be something that we wanted, may not be something that we planned for, but the planning in terms of the discussion with your family members might make a really horrific situation a little bit better. So I'm just going to play that next video.
Lorraine was diagnosed with a rare form of cancer about 2.5 years ago. It took a couple of months to actually identify the fact that it was a cancer, and once diagnosed, we found out it was a cancer where the average life expectancy is approximately 6 months. And the cancer progressed quite quickly. The surgery was a success, but unfortunately at that time they found that more tumors had developed. And then she unfortunately passed away about 4 months after that. So I think one of the challenges of cancer care is that there's a lot of different opinions out there around what success looks like moving forward in your life. I think everyone hopes that you will survive, and I think everyone has a story or two about someone who defied the odds and did survive. And so you'll always have people who will be trying to, in some way, often in a very well-meaning way, insert themselves into the dialogue around how you treat or how you approach treatment in dealing with your disease. And I think it can be very challenging. So when it came to decision-making at the end of her life and whether or not she would be able to make decisions, I think we were very naive and very lucky. We had talked in advance about what we wanted to have happen, but I don't think we fully appreciated how rapidly these things can come on and how it can impact the person's ability to actually make decisions. She was probably until the last week of her life, she was very involved in decision making, maybe the last 2 weeks. But again, I think we were fortunate because I know of other situations with other families where something like that happens much more quickly, and people don't appreciate how much more of a struggle that can be once the person is no longer part of the decision-making process. I think the main benefit of having the green sleeve was actually knowing that you could take that with you under any medical circumstance and know that the goals of care designation would be honored by whoever that you were interacting with from a healthcare perspective. The advice I'd give around advanced care planning is it's never too soon to be talking about it. I think even before something happened to us from a medical perspective, we were talking about it philosophically. I think we all like to think that something like this will never happen to us, but the reality is, unfortunately, it sometimes does. And you're so much better off having had those discussions in advance than having to deal with them with all of the combined stress of what is happening with you medically, plus the family consequences and everything that gets piled upon you. So to have had a rational conversation in advance of that, I think was critical to us being able to deal with things in a very timely and, you know, the smoothest possible fashion that it could have been dealt with. I think everyone hopes that you survive a cancer diagnosis, And what we learned from our experience is sometimes hope becomes spending the best time you have with your family and friends during the remaining time you have in your life, or spending the best quality time possible with your family and friends in the remaining time you have left. So the idea of reframing hope was one of the most valuable things I took away from the experience.
So in terms of the personal directive and the goals of care and sort of where does that fit, is in terms of you can put in your personal directive that you don't want CPR or these are things, but you really do need that goals of care. It's because the personal directive is kind of in the future, but when it's enacted, then we follow it, right? When you lose capacity, then we follow it. The goals of care is the care you want right now. And that needs to be signed by a physician or a nurse practitioner. So they're kind of related, but not. So what you need to know in your head is personal directive is future, goals of care is what I want right now. So certainly, you know, I showed you the, sorry, this is a repeat. I showed you the medical assistant dying website is there. This is the green sleeve. This is your health passport. I know it has a different connotation now, but in terms of we had it first, the green sleeve is actually the container of your advanced care planning document. So what should go in there is a copy of your personal directive and the original of your GCD order form, if you have one, and the tracking record. And the tracking record is where your healthcare team would chart any conversations they had about your goal of care, about maybe even your personal directive, but that's your property. So you get the originals and you put it in your green sleeve. And people ask me, why do I need a green sleeve? Why do I need to carry that around with me? And I know that we're getting more and more on the computers, but unfortunately, every section kind of has its own computer system and they don't talk to each other. So if you have a green sleeve, you need to take it to the emergency department with you. You need to take it to your specialist. You need to take it to your family physician. You need to take it when you go out. My mother has a green sleeve in it. It says her goals of care. And when she goes out, when I take her out shopping, when I take her out, when she comes to my house for a visit, that green sleeve is in the back of her wheelchair. Because if something happens, and remember, if the EMS come, they will know exactly what kind of care she wanted because she's got her green sleeve with her goals of care in it. Then some people ask the questions, do I have to carry this with me everywhere? Well, you don't, but if it makes a difference, like it makes a difference to my mother, she wants to make sure she gets the care that she wants. Otherwise, if you have a goal of care and we don't see it, then you're going to get R1 care. We don't have a smaller wallet card. Unfortunately, we just have the green sleeve. And we don't just know your GCD. It's like I said, even though there's all kinds of computer systems, they don't talk to each other. We can't use the medical alert bracelet because it's not a signed document and your GCD can change, right? The doctor and you may have a discussion and decide on one goal of care. And then later down, if your healthcare changes, you may have another goal of care. So the medical alert bracelet wouldn't be that easy to change. Some people out there still have a capsule of life. It was given out, I think, by the fire department. I don't know if it was big all over Alberta, but I know it was in Calgary. The capsule of life is meant to have contact information in your home if something happens. And the green sleeve is different because a green sleeve is a live document, like our video said, that travels with you, right? That is changed, that is looked at on a regular basis. So I just have one more video and we're almost finished. And this is just about the green sleeve, so you have a good understanding on how to use it.
A green sleeve is a plastic pocket, like a medical passport, that holds important advanced care planning documents. It is recognized by all Alberta Health Services healthcare providers, so that in an emergency, medical professionals will have access to your personalized advanced care plan and know your healthcare wishes. You may get a green sleeve from any Alberta Health Services provider, either in hospital or the community. You can ask for one, or your family doctor or nurse may suggest you have one. The green sleeve is your personal property, and you should only have one that contains the most up-to-date documents. The green sleeve holds 3 forms: a copy of your personal directive and 2 Alberta Health Services healthcare forms. A personal directive is a form that you complete. It outlines important healthcare decisions, such as where you might want to live, or what would be most important to you in your life if you weren't able to communicate. Anyone over 18 should have a personal directive. You can complete a personal directive with or without a lawyer, and you can use the blank personal directive form provided in the green sleeve. In the personal directive, you name one or more persons who you trust to make personal and healthcare decisions for you if, in the future, you can't make them for yourself because of illness or injury. The person you choose is called your agent. The Goals of Care designation form is a medical order completed by your doctor or nurse practitioner based on conversations between you and the healthcare team. You do not write on this form. A Goals of Care designation, or GCD as it is referred to, is an actual letter number combination that helps the healthcare team quickly know and interpret your goals of care. Not everyone needs a GCD, or Goals of Care designation. However, it is useful for those individuals when it is important to know and act on their unique healthcare wishes. The tracking record accompanies the GCD form as a written record of your advanced care planning discussions. When all 3 of these forms are put in the green sleeve, this package becomes the one source of truth that reflects your wishes and values for healthcare. At home, place the completed green sleeve on or near the fridge, as this is where health responders are trained to look in a 911 emergency. It is also recommended that you provide a copy of the green sleeve to your designated agent, family, and healthcare provider. It is also a good idea to bring your green sleeve to all health appointments. Remember, the green sleeve is like your medical passport. It holds important legal documents that go with you through the healthcare system. If you don't have a green sleeve, ask your healthcare provider for more information. And if you already have one, keep it current and easy to access in case of an emergency.
So there's 3 takeaways. We say don't wait. If you haven't had the conversation or if you haven't written your personal directive yet, there's never going to be a good time to do it. So do it as soon as you can. You don't need to be an expert in goals of care. The main point of tonight's discussion around goals of care is so that you have some familiarity with it and that it is really a discussion between you and your doctor. And to remember that that green sleeve is your medical passport. Where you can get information is on our website, Conversations Matter. When you go to that website, you're just going to click on the Patients and Families tab. That's going to give you all kinds of information about the green sleeve. It's going to give you information how to order a green sleeve if you need one. You're going to have access to the guidebook, which comes in 7 different languages. So it's kind of a really helpful, everything you wanted to know about advanced care planning in Alberta. So this is our Conversations Matter guidebook. It goes through all the information that I've talked about tonight. It talks about the personal directive and the advanced care planning, and it goes through the goals of care like I did tonight. And I really think that it's a great little booklet. You know, if you have one, share it with your family and friends so that everybody has information about advanced care planning and goals of care. So I am going to stop for questions, see if David's got anything.
Hi, Alexandra. Yes, we've received a few questions in the Q&A. I'll start off with one from Don. A relative recently moved from BC to Alberta. He has just been diagnosed with terminal cancer. In his BC personal directive, is his BC personal directive valid in Alberta? I think you've touched on it a little bit, but did you want to expand on that?
Yeah, so as long as it's signed, witnessed, and dated, I would just make sure that it says what he wants it to say. Is it very clear on terms of that? And just like I would point out, sometimes when you're going to different health facilities, they don't have the same education. You would have to point out that even though it's from BC, it is signed, dated, and witnessed, and it is a valid personal directive. So that would be the only thing that sometimes people are a little taken aback if it comes from a different province, but it's right in our Personal Directive Act. We can accept anything that as long as it's signed, witnessed, and dated.
Okay, great. Another question from Wendy. There's a personal directive registry with Alberta. Do you think it's a good idea to do it?
So what the registry is, it's not extremely well used. What it does is that it registers that you have a personal directive. They don't keep a copy of your personal directive on file or anything. The best thing you can do is make sure that your agent has a copy, that your friends have a copy. That's kind of a better way, because if an emergency happens, it's going to take a bit of time if they go to the registry, and the registry is just going to give them information that you have one. It's not going to give all the rest of the information on there. So I think the best thing you can do is to make sure that you have your friends and family know where your personal directive is, or even have copies of it.
Excellent. This is from Blair. My husband and I have a personal directive. However, communication between AHS and family doctors is often poor or non-existent. How can I assure my family doctor would even know I am in the hospital and want my wishes carried out? A friend recently was getting chemo at the Cross, but her family doctor did not even know she was getting chemo.
Well, unfortunately, that's a little bit above my scope in terms of I can't solve all the world's issues, and that is an issue. All I can say is that hopefully we're getting new electronic systems in, and information should flow better. I don't think it's any guarantee, and it is a big, huge issue in terms of communication. What I can say about the personal directive, if you're advocating for someone, make sure that people know you have a personal directive, make sure it's on the chart. If you're the agent for someone, make sure that you let the people know that you're the agent and they have a personal directive and the documents go along with it. Unfortunately, your best advocate is yourself and your family to be able to sort of go through the system. Unfortunately, I can't solve all the problems with the system.
Fair enough. Our last question, how often should my advanced care planning kit be updated?
So I would just review it a year, but what they say is if you've had a change in your health, or if you've had a change in your life, like a divorce, maybe there's been a death in the family. Those kind of things should trigger you. Oh, maybe I should look at my documents, because maybe your agent is no longer able to be your agent. You don't want your husband or wife as your agent, maybe after a divorce, although I've seen it happen. It can work out well, but those are the kind of things that you're looking at. Or maybe you have a health condition that's going to change what you want to have in your personal directive. So that would be a great trigger to say, you know what, this is the time I'm going to change my personal directive to reflect more. I have a personal directive right now, but 5 years from now, I may decide to change it because my situation may be different. But if I, had a diagnosis maybe next week or next year, you never know, then I would change my personal directive then to maybe reflect my position.
Okay, great. Well, that was all the questions that we received, Alexandra. So thank you for taking the time for answering those. Terrific presentation. I'd like to take this opportunity to thank our Calgary chapter for organizing this evening's session with Alexandra. If you have any other questions following tonight's session, please feel free to reach out to our support team via email at support@dyingwithdignity.ca. Also, a friendly reminder to please take a few minutes after the session ends to answer a couple survey questions. Thank you very much for joining us tonight. Have a wonderful evening.
Bye-bye. Thank you for coming.